questions till the end so we can get through this, okay? But we're going to talk about sleep, alertness, and fatigue and medical training. But can somebody tell me what this is? Yeah. Well, actually, it's not. It's Metro North. Right, okay. I couldn't get a good picture of the Hoboken train station with that crash coming in, because the big thing the next day was, did a microsleep cause this deadly train derailment in New York? 4 people were killed in this accident. And what ended up happening is that the conductor had sleep apnea and had not been being treated and fell asleep while he was going into a turn and traveling much faster than he should have, and had a microsleep. So a couple of learning objectives for this. I'm going to try to list the factors that put you at risk for sleepiness and fatigue, describe the impact of sleep loss on all of our lives, both personal and professional, try to help you recognize the signs of sleepiness and fatigue in yourself and others that are not obvious, okay? We know there are some obvious ones. And challenge some common misconceptions that we among physicians have about sleep and sleep loss, and talk about some alertness management tools that I hope you can adapt for yourself and maybe within your program. So I have a couple of questions for you to think of. I want you to think about how many hours of sleep do you get on average? How many hours of sleep did you get on your last on-call night? How many hours of sleep did you get on your last post-call night? And you'll see why some of these are relevant. And how many hours of sleep did you get on your last pre-call night? Now, we all talk about how much sleep we get and how much sleep we should get. And a couple of studies, this is a Gallup poll, showed that only 28% of people get 8 or more hours of sleep per night. And the American Academy of Sleep Medicine has actually changed their requirements for sleep recently and said that while most people should get 7 hours, it's totally variable, because we now know that your sleep needs are genetically predetermined. So there are some people who are going to need less sleep. There are some people who are going to need more sleep. And what you need to do is start judging it according to whether you can wake up awake and feeling rested. That's then how much sleep you need. So a little quiz to take to yourself, going to take about 10 seconds. I've got 8 situations listed on the left side of the slide. Sitting and reading, watching TV, sitting and inactive in a public place, a theater or a meeting, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch, a lunch without alcohol, and in a car while stopped for a few minutes. And I want you to give yourself, for each of those situations, either a 0 if you would never doze in that situation, a 1 if you've had a slight chance of dozing, a 2 a moderate chance of dozing, or a 3 a high chance of dozing. So the lowest score you can get is a 0. Highest score you can get is a 24. So just take a few seconds, add up your score, and keep it in your mind. Okay, everybody got a score? When you have an audience response system, if anybody wants to do this in another session, it's really fun to see what the spread is and include your nurses and everybody within it. So this is the person who started all the concern about sleep deprivation in residency training and in medicine. This is Libby Zion. She's an 18-year-old college freshman who in 1984 had an upper respiratory tract infection, developed a fever, and had some jerking motions. She had also been being treated for depression with phenelzine. Phenelzine's an MAO inhibitor, okay? Her father, in the meantime, was Sidney Zion, who was a very famous journalist in New York, wrote for the Times, the New York Post, the New Yorker, and had some very big connections, including Nelson Rockefeller, the then governor of New York, and Robert Morgenthau, who was the Attorney General of New York. With this URI, she was taken to the Cornell emergency room at 3 o'clock in the morning. And some of us older people who know what the Cornell emergency room was like in 1984, they didn't accept city ambulances. So I'll just tell you, it was not a very busy emergency room. They sent them to St. Luke's or something like that up the road. But any which way, she was admitted at 3 a.m. to an intern who had 40 other patients taken care of and was working 36-hour shifts with 12 hours off. Because of her jerking motions and being somewhat combative, she was given Demerol and put in restraints. She continued to get combative, was not seen when she was put in restraints. Intern and the resident saw her, her PCP did not see her. And what people didn't know along the way, and although some people contest this, is that she also had been taking cocaine. Okay? And what did that all have to do with it? But what's the problem with giving Demerol along with an MAO inhibitor? She developed temperature of 107 and had a cardiac arrest and died. What did she have? Somebody out loud. Right, and serotonin syndrome. So chairs of medicine said in 1984 that wasn't that well known, but the interaction was known. So these residents, the intern resident and the attending, were actually brought before a grand jury and had 38 counts, I'm furious now, 38 counts of gross negligence and or incompetence brought against them by the grand jury. However, all of these things had to go through a hearing committee of the state medical board who closed the charges, but the Board of Regents of the state of New York reversed the charges and voted to censure, reprimand the residents, and they were charged a fee, not put malpractice on their record, but they were charged a fine, which Cornell ended up paying. But with that, another connection, New York State Commissioner David Axelrod for Health and Human Services was appointed by Rockefeller to head a commission. He appointed Dr. Bertram Bell, who was the chair of family medicine at Albert Einstein, to put into order guidelines which would recommend how doctors should be trained and how much time off they should have. So in 1989, New York State adopted these recommendations, which are still in effect as of now. You know, you get something into state law and it can't be changed really. That interns and residents would work less than or equal to 80 hours a week, not averaged over 4 weeks like the ACGME says now. No more than 24 hours in a row with only 3 hours for crossover. And that there was supposed to be significantly more on-site supervision from senior physicians. So this started, as you can see, back in 1989. At the same time, there was evidence coming up from the Institute of Medicine reports, that said that 98,000 people died in hospital every year, some of it due to human error, one of which was sleep deprivation. And in the same time, people started developing an interest in sleep and circadian biology. So all this came together to say, what are we doing? How are we training people? How are we treating physicians? All of us, attendings as well. So the other thing that was going on is that we had these education and patient safety imperatives that were coming about at the same time. Clinical environment was changing with the acuity of patients, the short patient stays. Actually, the Committee for Interns and Residents, the union in New York, presented a petition to OSHA in 2001 that said because of resident sleep hours and fatigue, that patient safety, resident learning, and well-being was being compromised. OSHA rejected the petition at that point and said the profession needed to decide what was good for training and not. However, there were calls for more regulation like New York State on a federal level. And that became a major concern to people because once you get something into federal law, there's no looking back at it. The New York State law still exists and hospitals are still visited to see what they're doing as far as being able to get through their duty hours. People also started thinking about, residents are now doing a lot of time on non-educational activities. So what do we do with that? The secretarial activities that are being done, how do we help that? And that we've got more inefficient support system and greater coverage needs. And you guys know that more than anybody else because of the assimilation or the acquisition of the St. Raph's campus and what your coverage needs are. So to try to stop the movement of duty hours being regulated by the government, the ACGME in 2003 the president put duty hour standards into effect. They were supposed to wait for 10 years to evaluate their effect and then go forward. Well, the Institute of Medicine, charged by Congress to look at this, created another task force. They released a report saying, well, there was no problem with the duty hours, there was no bad outcomes, but maybe that's because we didn't do enough. So maybe we should put more duty hours into effect. And that's when ACGME said, you know, look, it needs to come from us, because the IOM task force also recommended that there be another body overseeing how we regulated those duty hours. So in 2009, there was another ACGME task force which put in the revised standards. And I'll tell you, the IOM task force standards were stricter than the ACGME ones are right now. I can tell you because I sat on that task force, so you can kill me if you want to for the present duty hours. But what we all agreed upon is that duty hours are really just a surrogate marker for fatigue. What we don't have is a simple fitness for duty test. You know, to look at cognitive and psychomotor function when somebody's been up and is sleepy, has been up for a certain amount of time, how do we know to say, you're sleepy, you go home? I can't look at Dr. Foster and say, you know, you're tired, go home, you shouldn't be operating right now. I have no way to look at that. The Army and NASA is trying to do that. They actually have a 3-minute test that you can administer to say, your psychomotor testing is down below a certain level, you need to go take a nap, which we'll talk about. So remember your score from the first thing on the 0 to 24? You took the Epworth Sleepiness Scale, which is a sleep test that is administered in sleep labs when people are referred to sleep labs. So in this, this is a big compilation of studies. Normal score is about between 7 and 9. In this study, compilation of about 4,000 people, normals had a score of about 6, insomniacs had a score of about 2, sleep apnea patients had a score of 12, narcoleptics had a score almost of 18, and residents had a score of 15. So all of our residents are functioning somewhere between having sleep apnea and narcolepsy. So just think about it when you're talking to some people on the phone. And I would bet this is the attendings, I'm not going to ask you to tell me, are all somewhere within that range as well. So I told you there's a lot of stuff being done on sleep deprivation clinically and experimentally. So we know that there's a change in neurobehavioral performance, decreased sustained attention time, decreased reaction time, decreased vigilance, and decreased cognitive performance, memory, reasoning, and problem solving. We now know that after one night of missed sleep, you have a 25% decline from baseline in your cognitive testing and your psychomotor testing. After 2 nights of missed sleep, you have a 40% decline. So it just doesn't decline 25% and stays there. It keeps on going down. So it is cumulative. The sleep people consider sleep of 5 hours or less every night to be chronic partial restriction of sleep. And with that, they've been able to show that that produces cognitive performance deficits similar to that of total sleep deprivation. So, you know, maybe unless we're genetically programmed to need less than 5 hours, there are some of us who are walking around chronically sleep deprived. Think about that for yourself and what effects that may have on your health otherwise. So what causes sleepiness? You know, the common beliefs. I told you some common misconceptions. It's the boring noon or morning conference. It's the room. It's too dark. It's too warm. It's too cool. It's the food. It's got too much carbohydrate. It's too much sugar. It has nothing to do with that. What it has to do with is your circadian rhythm. Okay, and your circadian rhythm is a balance between your drive for sleep and your drive for wakefulness, which results in what they call a wake propensity. And circadian rhythm usually goes over 24 hours. People are now saying maybe it's 25 actually. But that you have a peak of wakefulness somewhere coming up starting at around 10 a.m., but peaking at around noontime, 11 o'clock, noontime, and then right after that, your sleep drive starts to take over. So you have this dip, which is right after lunch. So that's when most people get sleepy. sometime in that time. You have that little bounce up again so that you get awake somewhere around, awake somewhere around between 8 and 9 p.m. And then you really, sleep takes over. You are at your sleepiest between about 2 a.m. and 6 a.m., 2 a.m. and 5 a.m. And you're at your sleepiest during the daytime between about 2 p.m. and 4 p.m. So think about that as you're going through your day. Let's just review the stages of sleep for a second. So you've got non-REM sleep, stage 1, you've got stage 2, stage 3 and 4, most restorative stage of sleep. That's the thing to remember. You need to get to stage 4 to be able to have your brain restore itself, restore the proteins. And they've looked at this at functional MRI testing. And then REM sleep, when you start to come back, it's really associated, as you know, with dreaming. It's the most functionally active time for your brain. So look at a sleep study. On the top is a normal sleep study over an 8-hour period. Somebody's awake, goes down, hits stage 3 and 4, comes back up, has REM, goes back down, comes back up, still hits stage 3 there, and then starts to wake up. This is the elderly. This is on-call sleep. How many times do you get down to stage 4? This has been done on multiple people. You never get down to stage 4 most of the time and never get that restorative phase of sleep. Why is this? Residents, you can tell me why this happens. Beepers, phone calls, all that stuff. What's the other group of young people who have this happen to them? Maybe a little bit older too. Parents. Right, parents. Getting up every 2 hours in the middle of the night. My daughter now has a 3.5-year-old and has 16-month-old twins. So you imagine what her time right after she had her twins was like. 15 minutes of sleep maybe in between feeding all those kids. So when she got really cranky, we knew it was her sleep deprivation, not anything else. So there are lots of things that cause what we're saying is excessive daytime somnolence in medicine. Insufficient sleep on call, insufficient recovery time, fragmented sleep and pagers, circadian rhythm disruptions with rotating shift work. Nursing staff is very concerned about this as they rotate people from shift to shift in emergency room physicians and nurses. But then all of us can still have sleep disturbances such as sleep apnea, restless leg syndrome. We're not immune from those. But let's quickly talk about some of the consequences. I'm going to try to go through some of this quickly. Effects on patients. This really looks at people having days of sleep deprivation and doing a routine test, an attentional lapse, a repetitive test that every time they hear a sound, they responded to it by hitting a button. And you can see with total sleep deprivation, this red square is going up here. Doesn't take long before you're really off the chart in how many sounds you miss, so how your attention disappears. At 8 hours nightly over 14 days, you're pretty good, but somebody can say, well, you're still going up. Why are you still having attentional lapses? And people think it's probably because of test fatigue as you keep on going forward. This was a self-reported study Baldwin did. Again, it's about 3,500 residents responded. And they looked at errors they reported and adverse events that they thought they had when they were getting less than 4 hours, 4 to 5, up to 7 to 8. And you can see the errors reported went down with the more sleep they got. And the adverse events still went down, but what's nice to see here also is that the adverse events were much less than the number of errors reported. And it's probably all because, even though this was in 2004, the mechanisms that are put in place now to prevent errors from happening, nursing redoing things, the readback things that we do now, all we're putting the blocks up in the Swiss cheese so Let's gets through. So that's nice to see. This is one of the 2 randomized controlled studies that was out at the time that the new ACGME requirements came back. This was done at the Brigham. They took interns in the ICU and they put them either on a regular 30-hour shift every 3rd night or a 16-hour maximum schedule. They put EEG monitors on them, they put lid droop monitors on them, and they monitored what they did, how their attention was, and whether they had attentional failures while they were on duty. The people in the blue were the traditional Q3, 30-hour shifts. The yellow and a couple of the slides that follow are the same thing. People in the yellow had significantly less attentional failures. These were only interns, only PGY1s. The same group actually then looked at how often there were serious medical errors, serious medication errors, and serious diagnostic errors. And again, there were significantly less in the people who were on the 16-hour shift versus the ones who are on the Q3. At the time we put out the new ACGME regs, these are the only two randomized control studies that we had, and they were both in PGY1s. So if you're questioning why was the rules only in PGY1s for 16 hours, that was the main reason. We also couldn't understand how anybody could follow the IOM recommendations where nobody should do more than 16 hours. And could you imagine all the shift changes and patient transitions that would be if everybody did 16 hours? They said if you couldn't do 16 hours, you had to have a mandated 5-hour nap somewhere between 10 p.m. and 6 a.m. Think about the transitions of care in there as well. So we went on what we thought was evidence at that time. So there's a couple of studies that have looked at what happens if people stay up all night in real life. This was a little older study, 2009, but it was the risk of complications by attending physicians after performing nighttime procedures. And they looked at consultant surgeons and OBGYN. This was done in Great Britain, or Canada, sorry. And they saw no significant increase in complications in post-nighttime procedures versus control. But in the consultant surgical cases with less than 6 hours, they had substantially elevated rate of complications. Problem is that their sleep was assessed retrospectively, and they weren't sure how accurate they were in the amount of sleep they got. There have been lots of studies, and I'll show you the one that's most quoted now, that look at decreased medium-term psychomotor and cognitive performance changes. Everybody agrees that laparoscopic skills suffer on the first shift of sequential nights. So when residents go on night shifts, on night call, their first night on doing laparoscopic skills will be worse than their 7th night on night shifts. But their recent studies haven't been able to show these same outcomes, which have been poor. But somebody pointed out that the studies have been small. They've mostly been performed in Scandinavia, and maybe because the number of real lifetime hours up in Scandinavia, people are used to that any which way. Uncertain. But this is the one that came out in 2015. This was in the New England Journal, as people were starting to say, maybe attending surgeons should not be doing elective cases the next day after being up all night. This was a population-based retrospective matched cohort study in Canada. They looked at 1 of 12 elective daytime procedures in a physician who had treated patients from midnight to 7 a.m., and they were matched in a 1-to-1 ratio to patients undergoing the same procedure by the same physician on a day when the physician had not treated patients after midnight. Big group of patients, 38,000 patients, almost 1,500 physicians, 41% at an academic center. And what they looked at were outcomes including death, readmission, complications, length of stay, and procedure. And they found no significant difference in the primary outcome and no significant difference in outcomes after stratification for academic versus non-academic center, physician's age, or type of procedure. So people have quoted this study as reason not to put limits on attendings being up all night the night before and continuing to do big elective cases. But I think a lot of institutions have looked at that in their own way and decided what to do from their own medical staffs. This is just a quick slide from the Medicare records that looking at morbidity and mortality and readmissions after the new duty hours took place, and basically huge number of admissions, 6 million. This is one of these big data studies. And what they found is that there was no change in the 30-day mortality rates or 30-day all-cause readmission rates in Medicare recipients. So at least the duty hours didn't have a bad effect on things. Can't say that it had a good effect, but didn't have a bad effect. So with that all, there were 2 studies that were started, and some of the residents were probably in, no, actually, you guys weren't, because our surgical program didn't get enrolled in this. Study called the FIRST trial, was Flexibility and Duty Hour Requirements for Surgical Trainees trial. And what they did is they randomized certain rotations, or institutions got randomized to either a 16-hour shift maximum or the standard 30-hour shift. And they did it for a year. And what one of the problems was is that it was only a year, and their major outcome was death and readmission. So thinking about that, what could you really tell in a year? And we weren't sure what it would actually come out with. So we didn't participate in this study. What the study showed after a year was that there were non-inferior patient outcomes, almost 140,000 patients, and no significant difference in the resident satisfaction with the overall well-being and education quality, which I think was disappointing to a bunch of people. They thought there was going to be an improvement in the resident satisfaction, both with well-being and education quality. Internal medicine has done the same study called iCompare. We did participate in that. They're going on to a second year. But in the meantime, there was a big to-do last year that the Committee on Interns and Residents again brought forward a charge saying that the study wasn't valid. Interns weren't asked to participate in it before they matched in the institution. Patients weren't asked if they wanted to be taken care of by people who had stayed up for 24 hours. And it's calmed down now because the people have said, we don't know what the data is in residents and in physicians, attending physicians. We need to get more data. But, you know, people use that first study to basically say, oh, we can keep you up all night, but if we have to support you, you know, our interns work extremely long hours. The harnesses will help keep them awake during your operation. What patient is going to want that? Yeah.
I just wanted to comment on the first study, on the first.
Right, right.
So, I mean, I think some of the data that you didn't mention was that in the flexible hours groups, the group was the residents who worked fewer hours reported that they left the operating room more frequently. They had to leave cases more frequently. And they also reported that they had to do more handoffs and care. And so, yeah, I think it's my take home as a surgeon and someone who, you know, helps train residents is that it seemed like the longer work hours, residents, it didn't have any impact on people's reported quality of life. There was no safety impact. But if you then try to move people to shorter hours, they have to leave the operating room more frequently and there's more handoffs in patient care.
Right. So the ACGME right now is re-looking. They've had an announcement out a few months ago, and Harris can probably distribute that to you, is that the new common program requirements are going to take away that 16-hour rule for interns. It'll be up to programs to decide what they want to do, and people could stay longer than the 24, but they really have to be doing it not as a planned exercise. So things like having to be in the OR for a good case, not leaving the OR, being in the ICU taking care of a patient. It's not going to be looked at like the New York State looks at it, that the hospital gets fined when they come in and find out they're doing that. And they're going to be doing some more studies to try to see what happens. There have been a couple of studies that looked at in the people who are on the 16-hour shifts, why their well-being didn't get that much better is because they went home and they did things like go to the dentist, take their clothes to the cleaners, do the wash, play with their kids. Education didn't improve because they didn't spend time on education. So what's the balance? And that's the big question. And that's why this trial and the iCompare trial were started, because we really needed something to look at the difference and see what happens in a clinical laboratory, research laboratory with sleep deprivation is the same thing that happens in a stress situation like medicine. There is a PhD in psychology at Yale who is working on, mainly with the armed forces, something called stress inoculation, and looking at what stress, being under stress all the time, does to your circadian rhythm and your ability to function and your psychomotor function. That's going to be the interesting thing to look at. So I think we don't know where we are, but yet when you have a study come out where the Committee on Interns and Residents random dials 300,000 people on phone and asks, do you want to be taken care of by a physician who has been up for 24 hours? Or do you want one who's gotten 8 hours of sleep the night before? Of course, the overwhelming answer is, I want someone who's gotten sleep the night before. You know, and as long as that's out there and we haven't been able to explain to people what it takes to train physicians, like being able to complete a case in the OR, not having to transition care so many times, getting back to the feeling of ownership for the patients, which some people think has disappeared with these duty hours. We're not going to know, but you're not going to get those people to be able to see that unless we can prove something. You know, if your doctor comes in the morning before your case and the eyelids start drooping when they're talking to you, you're going to say, I don't want that person operating on me, you know? So it's something we have to really look at. So I'm going to do a couple more slides and then I think we're going to cut, and I'm willing to come back to do the second part of this talk. And maybe we could talk about prostate screening continuing going through. But I'll just, with that thought, the neurosurgery people have gotten really hot about this, and I thought I'd put this in there for you because I presented it to them. And this is a 2016 paper. They did a review of the literature, and they looking at what happens with non-neurosurgical and neurosurgical residencies. So there were 9 papers in neurosurgery, and what they saw is that there was no decrease in medical errors, decreased productivity, increased patient handoff, increased post-op complications, M&M for meningioma and teaching versus non-teaching hospitals was less. Post-call fatigue didn't diminish their neurosurgical skills at tasks. Cost of increase, for that should be a P for spine patients. The night float system has helped maintain the case volumes. So the question is where to go. And they said, maybe neurosurgery should split off from the ACGME for regulations. And their other closing statement is, we believe that the importance of patient care, operative experience, and education outweighs the perceived risk of neurosurgical resident fatigue. Unique parameters for neurosurgical training programs should be considered. If you were a layperson, putting it that way, wouldn't you think this is a little crazy? You know, you've got a lot of data out there about what happens in, you know, experimental things. After 16 hours of sleep, your testing goes down. Why do they think they're so special that they could get away and not make mistakes on my brain? You know, so there has to be better communication and better information about this stuff in medical training, and better communication with the patient population out there about what it takes to train physicians and how we're supervising people, so we're not letting people out there who are interns or PG2s with little supervision because the attending physicians are also falling asleep. Okay? So, do you want me to stop, Paris, or what do you want to do? We're on page, we're on slide 35 out of 75, so this is...
Yeah, we've got probably.
Okay, I'm willing to come back and give you the rest of it, which will talk about fatigue mitigation and what effects we know that it has on you as trainees, and what you can maybe do to help yourself and how to look for signs